So, kia ora koutou, and welcome everybody to another lunchtime seminar. Today we have Bronwyn Thompson presenting to us. Bronwyn is a clinical senior lecturer in the Department of Orthopaedic Surgery and the Musculoskeletal Medicine at the University of Otago. She's worked for most of her working life in the field of pain management, and her roles have ranged from occupational therapy, pain psychology, to vocational management and policy development. Now today, she's going to talk about raising the topic, finding out the person's main concern, what matters to them, why sleep management is important, developing a pain plan, medication adherence, and coping strategies. And yes, without any further ado, I'd like to welcome Bronwyn and invite her to start the presentation.
Hi, and thank you so much. Kia ora, everyone. It's wonderful to have so many people, and I can see some occupational therapists involved, which is just wonderful. And I hope we have some physiotherapists, some nurses, and others as well. For my favourite topic, pain. Yeah, I know, I'm sad, but you might. For those of you that don't know, my background's occupational therapy, and I grew up in Gisborne, and I saw there were some people from Wairoa. So I know the East Coast fairly well, but I moved south quite a long time ago, and I am now residing in Christchurch. So what you can see in the image behind me is the view across the water from where my office is. I'm on the lower ground floor of Christchurch Hospital. But I work for the University of Otago. So today we're talking about pain, and normally when I do a talk about pain, I talk about all the problems that we have associated with managing pain, and chronic pain is a problem. But I wanted to shift the conversation a little bit and move towards some other ideas that we can have and use when we're looking at helping people who have pain. So chronic pain, what can we do to help? I want to set the scene, first of all, with some numbers, which are quite disheartening. So 1 in 5 New Zealanders live with pain that's lasted 3 months or more, according to our New Zealand Health and Disability study and the 2016-2017 study. That doesn't tell us how many people have pain that gets in the way of life, but it does show that an awful lot of us in the audience speaking probably live with pain. We also know that about 63% of people in the mid-central region in the longitudinal study talking about health report that they have chronic pain. That was just published in Kaitiaki this year, and it's a really nice study to explore some of the problems that people who have ongoing chronic pain and other long-term disorders experience when they seek help. But it's actually a little bit worse than just the fact that we have a lot of people with pain. What we know is that people who report pain are also more likely to report other comorbidities. For example, in this study by Budge and Taylor, nearly 60% had hypertension, 44% with diabetes, respiratory conditions, depression and anxiety related to living with a long-term condition, problems with memory, angina, and in this group of people, over half had between 2 to 4 long-term conditions, of which pain is one of the main problems. So as we look at people who come into hospitals, who seek healthcare, particularly those who have long-term conditions, the chances are very high that the person that you're seeing has not only got their diabetes, but they also have pain of some form. And that pain could very well be getting in the way of what this person wants to do. But here's the sad part, that nearly 10% of the people in this study by in the Kaitiaki report showed that 9.2% hadn't seen anybody about their pain. That only 20% had gone to seek help from a physiotherapist. So most of the people with pain are seen in primary care by their GP. And that's not a problem, except that our GPs have very little time. And very often, pain's not the thing that's talked about first. Only a third in that study had a pain management plan. So had something documented to say, this is what I do about my pain to help me live well. Almost half had absolutely no idea about what they should do. And 17% said, I don't know whether I've got a pain plan or not. So that is a problem, because when people experience pain, their quality of life often reduces. So we know that there are problems with managing pain. We have problems particularly around the use of medications, and in particular in older persons, but also younger people, the use of opioid prescribing, which often doesn't help with the kinds of pains that are the most problematic for people. And we find that people overuse paracetamol because it's easy to access, it's seen as a very safe medication, and if 2's good, then 4 might be better. And we also know that there are problems with prescribing non-steroidal anti-inflammatories. Not only the gut problems, but the higher risk of cardiovascular problems as well. So medications that are the usual go-to for helping people with pain in the short term are not necessarily the best approach for people who need to live with pain in the long term. We also know that many people just don't talk to their healthcare professionals about their pain. In studies of knee osteoarthritis, people will leave that conversation about pain till the last comment that they make at the end of their consultation with their primary care physician. That last 5 minutes. Just before I go, by the way, doctor. And as a result, their pain doesn't get addressed, or it's addressed somewhat superficially. More than that, when people experience pain, things like their sleep, their mood, and their quality of life are poorer, especially in people whose pain just goes on and on. Whereas those people who feel like they've got their pain under some degree of management report that they feel better all around. So that's a really good thing. The trap is trying to help people get to that point. I'm just going to have a quick look at our chat just to make sure we've got some, make sure I'm not missing any conversations. So what can we do? There's no real simple single answer for persistent pain. And that's really because persistent pain, or pain that goes longer than 3 months, is not just one type of pain. The pain that can be problematic could be nociceptive. That's input that comes in via our nociceptive receptors, things like mechanical input, thermal input, hot or cold, can be related to chemicals like chili, pepper or onion. And that pain is generally fairly easy to manage. And it's not something we often see in everyday clinical practice. The second kind of pain that we have is inflammatory pain. So this is where two different situations. One is where we've got some tissue damage going on, we've got something active in the tissues, and our body's inflammatory response is dealing with that in an effective way. We get swelling, we get redness, and we get increased responsiveness of all the nerve fibers around that area that conveys a lot more information up to the brain to be perceived as pain. And inflammatory pain of the normal everyday sort, again, can be managed. It's usually short term. We can reduce it. In the case of the second type of inflammatory pain, which is like that autoimmune type pain, we're having increasingly effective approaches to reducing that inflammation. So in autoimmune disorders, it's our own body's response that's overactive and attacking tissues in a way that's not helpful and unnecessary. So if we can reduce the inflammatory response, then the pain also subsides in most cases. So both of those types of pain don't generally represent our long-term pain, except for inflammatory pain that hasn't responded well to our anti-inflammatory approaches. The two that really cause the problems are things like neuropathic pain. So that's like diabetic neuropathy or post-herpetic neuralgia, lots of types of low back pain, and the type of pain that we call nociplastic, where we've got some changes to the way our nervous system is processing the information that it's receiving. Things like migraine, irritable bowel, fibromyalgia fall into this kind of group. And the problem with looking at pain is, to the person experiencing it, it can be really difficult to describe the differences between what it feels like. The mechanisms are less useful for describing the experience that the person has. So although we can kind of determine neuropathic pain and we can kind of manage it a little bit if we catch it early, for lots of types of neuropathic pain we don't have very good descriptors. People can't describe it so well, we can't identify it very well. And with nociplastic pain, very often, because we can't see anything on scanning or blood testing, we can't determine whether somebody is for real or not. And that causes a bit of suspicion, especially when people then say things like opiates just aren't working. So we know with mixed types of pain, lots of people have a combination of different types of pain mechanisms that even in then, a single type of medication isn't going to work. And part of that's because the mechanisms are complicated and because pain's an experience. And as an experience, it's not just the biology. It's also this person's understanding of what's going on. It's also the impact on their relationships with others. It's our attitudes towards people who have pain that we can't explain. It's all around the way that we view generally that pain ought to be related to something going on in the tissues. And if we can't find those things that are in the tissues, then we go, huh, that doesn't make sense. And so for a lot of people with ongoing persistent pain, getting a diagnosis is not very easy, particularly for people with neuropathic and nociplastic pain. For people with things like fibromyalgia, it is a diagnosis of exclusion. So we try to find all the common causes of widespread body pain, and when we can't identify those, we're left with the conclusion that possibly this is this weird pain called fibromyalgia. And knowing the cause of the pain doesn't necessarily mean that we can do very much about it, particularly with those two problematic types of pain, neuropathic pain and nociplastic pain. We've got two drug groups that we can use, and the effect of those is not great. Takes about, for every 4 people that we treat, there'll be one person who'll get what we call in pain circles a good outcome. That's a nice 50% reduction in pain. It's about 1 in 4 people will get that from medication. The other 3 will not be so lucky. And it's those people that we tend to see coming into healthcare with long-term pain that hasn't changed, that is difficult to explain, hard to understand, and even worse to live with. And so what I've been looking at over my clinical career are some of those simple things that we can do that we know can ease the burden, even if we can't take all the pain away. So here are some simple things that we can do. The first step, I think, is inviting the conversation. if we know that a lot of people just don't talk about their pain because it's not the primary reason for seeking healthcare, something else might be, or because it's just a sign of getting older, particularly with osteoarthritis type pains, or because people are embarrassed or ashamed that their pain hasn't gone away. They wonder, are they making it up? Are they feeling, are they just, exaggerating? These are the sorts of thoughts that people can have about their pain. And so they don't talk about what it's like and the effect that it's having on them. So some of the things that we can do, if you're in primary care, we can have pamphlets, brochures, posters up and available alongside your breast self-examination and your cervical smear. Let's have something that says, if you've got pain, talk to us, we can help. We could be able to ask people to look at some of the free resources. And I've put a link to a booklet that was developed by the New Zealand Pain Society, pain resource. It's called Navigating Pain. And it was developed by physiotherapists, occupational therapists, nurses, medical practitioners, psychologists, to give some simple steps that people can take to navigate their own pain, to work out what to do and what might help. Other similar sorts of resources are the Health Navigator website that has a wealth of information available on managing pain, and particularly self-managing pain. Because the truth is that even if people get physiotherapy, for example, for their pain, most people who live with ongoing pain are going to spend most of the time on their own, needing to do things in everyday life that help them live a good life. We call that self-management. It's not really managing the pain, it's actually managing life. And that's the part that's the tough part. Because I don't know if any of you have tried to do, set yourself a New Year's resolution. I have, and I know about how long it lasts. 24 hours, maybe, if you're lucky. Changing habits is really difficult. And when we're looking at managing pain, that's the tough question. So how do we do that on an everyday basis for the rest of life? So a second step that we can do is invite the people that we see who we've already said, hey, have a look at this poster up on the shelf. Look at this, says, come and talk to us about your pain. Let's invite the people to develop a pain plan together with us. And in this conversation, what we want to find out is what matters most. This is things like, is it your sleep that's the most problematic concern for you? Or are you more worried about whether this pain is a sign of your prostate cancer returning? Or are you worried that this might mean you have to change your job? Or are you worried that perhaps you don't have a diagnosis and you don't know what's going on? Any one of these things could be uppermost in this person's mind. And we often think as health professionals that it's the pain intensity that's the thing that we should care about the most. But most people who experience ongoing pain, it's not so much the intensity, it's what the pain might mean. Does it mean I've got a cancer going on in my back? Does it mean I'm going to end up in a wheelchair? Does this mean I need to stop doing my exercise? Does this mean I need to have surgery? Or I have to take medication? These are the sorts of things that people are really asking about and wondering about when they first seek help. It's nice to get a label for the pain, a diagnosis, but a lot of the subsequent questions aren't around how can I reduce the pain, but answering these questions. What does it mean? So we can have a conversation about what's the most troublesome thing about your pain? What matters to you about your pain? How can I help that? and develop a plan that puts together some practical steps about where we should go from here. It might be, my sleep is really awful and I find I can't relax when I get home because I'm just so tired, so I've stopped exercising. In which case we can sit down in a pain plan and work out some simple steps about how we might be able to start exercising again, how we might have better sleep, and how we might be able to do some problem solving around some simple steps that I can do to help me relax. The third point is always ask about sleep and mood. Now, why is this important? Well, I don't know about you, but when I am feeling bright and breezy and I stub my toe, I swear once and I probably limp and then I run away and it's fine. But on a blue day, when I'm feeling a bit down the dumps and when the weather's a bit foul and I stub my toe, that's when I'm most likely to feel very unhappy indeed, and the swear words will come out and much more. So pain gets in the way much more when we're feeling down. Also, when we've got ongoing pain, it's likely that we're not feeling that chirpy. The two seem to go hand in hand. And what I'm not saying here is that low mood causes pain. There's a relationship there. It's not very straightforward. But if somebody's feeling down in the dumps and they've got pain, treating their mood is a really important, good step to take. And many people with long-term pain do feel depressed, disheartened, demoralised, basically fed up, because their pain's always there. And sometimes it's not just that the pain's there, it's that they've had to try and convince people, I really do have pain. And yes, it really does get in the way. The second question is about sleep. And the reason that we need to talk about sleep is because longitudinal studies where we've looked at one person repeatedly over the course of a couple of weeks, and we do that with a series of people, show that if we have really bad sleep, this increases the risk of really bad pain the next day. In fact, having a period of poor sleep for several months predisposes people to developing longer term pain. So it's not the pain that causes the bad sleep, it's very much more the bad sleep creates worse pain. So one of the ways that we can help people is to reduce their pain is to help them have a better night's sleep. It also helps better manage your pain if you're not feeling absolutely fatigued because you're not sleeping very well. So some of the simple steps that we can take is to have a look at how can we improve the quality of your sleep. Are you getting enough sleep? Sometimes this is just about working out whether this person's actually got a problem with sleep. Some people fear that they have a sleep problem. They're waking feeling fully refreshed, but because they don't sleep the normal 7 or 8 hours, they get really worried that perhaps they aren't sleeping properly, and that can create its own problems. But if somebody has got a sleep problem, they're not waking up feeling refreshed, they're having trouble getting off to sleep, they're waking up in the middle of the night and they can't get back to sleep, then we've got strategies we can use to help people. Medications are not the only way either. There's some simple strategies that we can use. We'll talk about them in a minute. And the final thing that we can do in raising the topic is to include a body diagram or pain questions in your intake form. So always include a body diagram. Please don't make it a really hunky male muscular specimen, because more women than men experience long-term pain. And as a woman, it's not very nice to have to fill out this muscly dude picture of where my pain is. Try and use an androgynous one if possible, or a gender-oriented one. But if you have a pain body diagram, asking people to show where they're sore, not just the one reason that they're coming to see you today, but where else they're sore, and then indicate the area that hurts the most or gets in the way the most. gives us a bit of an insight, some talking points about the fact that pain is a problem for this person. And we can also add some pain questions in the intake form. So, do you have pain that bothers you? And if it does bother you, what's it getting in the way of? What do you think's going on? Very simple questions that invite the person to tell you their main concern, what matters most about their pain. So that's the first step, really, is to invite that conversation, make pain something we talk about. The second question is to have a look at the impact of pain. And I've got two ways that we can do this here. One is the top sort of set of squares is based on the Australasian Faculty of Pain Medicine way of viewing pain, where they look at socially what's happening in this person's world as a result of their pain or alongside their pain. What's happening psychologically to the person? How are they feeling in themselves? What are the stresses? What are the worries? And then medically, what's happening in the body? What are the biological processes that are going on? We can have a look at the diagnosis. So sociologically, we can ask what's the diagnosis? Maybe this person's really socially isolated. Maybe they're just not getting on with people at work very well. Psychologically, do they have a mood disorder? Do they have an anxiety disorder or some other psychological problem? And medically, what's happening in terms of the diagnosis? Do they have an inflammatory problem? Do they have a neuropathic pain? Do they have something weird like fibromyalgia? Shall we have a look at how bad is it? So how much is this getting in the way? So we have an idea of just how much impact this pain in these various parts of the person's world, how much that is affecting their daily life and what they want to do. And then finally, let's have a look at the context. So what is happening in the environment? What's this person telling you about their life and the way that they're viewing their pain and the problems that are coming as a result of that? Occupational therapists amongst us will love the bottom model. This is called the Kawa model, and this is one of the models that we can, or the metaphors that we can use when we're looking at pain with somebody. We can have a look at the bed, the river bed, which is the context, who's around us, the environment that we live in. We can have a look at the logs that float through, which are the positive things or the variables that we can change. We can have the blocks or the boulders that live in the river that can get in the way of free flowing through of our lives through this landscape. And we can have a look at the person as a whole as they engage in doing what matters to them. That's what occupational therapy is all about, is saying what a person wants to be able to do that matters to them, the productive activities that we do, the occupations that we do, not just paid work. That these are the things that pain can get in the way of. So we can have a conversation about that. And that's where the impact of pain is most important, in what this person can do, wants to do, and is then able to do. We can ask what pain means, because the meaning of the pain can be worse than the intensity. If a patient I've seen who had prostate cancer and he'd had radiation therapy and that prostate cancer was now gone, but then he developed low back pain, he was worried. He thought, even though it's not very intense, it could be my cancer coming back. And that was really distressing. That's something we need to find out about. We can ask, what is your main concern? So when we have that conversation about your pain and what's going on and what your theory is about why your pain's still there, then we can find out, and so what is it about having this pain that bothers you the most? So that it's cancer, so that it's getting in the way of your sleep, that you can't get around to do your grocery shopping, that you can't do your daily tasks like making your bed or hanging up your washing, that it's getting in the way of having a good mood. And it's really helpful to ask, what's your theory? Why do you think you've got this pain that's carried on? Especially if this person has been unlucky enough to see a whole lot of different people about their pain. They can pick up different explanations, and it could be just a germ of truth from each person. They can also be given 5 different labels for what is exactly the same thing, pain. So it's really useful to find out what this person's understanding is of why they have their pain and what influences it. And the question that I most like to ask when we're looking at the impact of pain and where we can move to, rather than what pain's getting in the way of, is if pain wasn't such a problem for you, what would you be doing? It's almost like watching a person's face change when you see, well, if I didn't have so much pain, or my pain wasn't getting in the way so much, I'd be back working, I'd be doing this sport, I'd be playing with my kids, I'd be, just living life. And it's that sort of question that can form the foundation for that pain plan that I described. The next part is to routinely track the impact. And one way we can do this is what we call a recoverogram, which are 4 main areas of impact. Maybe sleep, maybe being able to walk, maybe being able to hang out my washing, maybe being able to relax. And we can track these on a 0 to 4, 0 to 4 scale, so that every time we see the person, we ask about these 4 areas that they've prioritised. We find out how are they going, where 0 equals, oh, feel terrible, awful, not working, to 4, this is fine, it's all working really beautifully. This is something that's very simple and it's personalised to this person. We could call it the patient-specific functional scale if you're a physiotherapist, or an occupational therapist might use the Canadian Occupational Performance Measure, which asks very similar questions and measures progress over time. But for the rest of us, this is a really nice way of just tracking what those very important activities and how well this person views their own capabilities. Because we've found that when people can do these things more comfortably, even in the presence of pain, they say that their quality of life improves. And often the strategies that we use are quite simple, as we'll go into in a minute. So step 3 is about let's develop some coping skills, and there are a whole raft of them around available for helping people with their pain. Often they're not about reducing pain intensity, because, as I said, the relationship between the intensity of the pain and how much it gets in the way isn't very straightforward. Because if people fear that this pain means my cancer, I've got a broken bone, my back's falling apart, I've got bone grinding on bone in my knee, that can lead to lots of fear that if I do things, it's going to cause ongoing damage. And so often it's not the intensity of the pain, it's what they think the pain means. If we can help somebody understand that the best thing that you can do for osteoarthritis and for inflammatory forms of arthritis is actually to move, we can reduce some of that fear that with my osteoarthritic knee, if I move my knee, I'm grinding my bone away. Actually, that's not what happens. That happens because of age-related changes and probably genetics. Instead, movement, exercise, call it what you will, can increase our ability to do things. And that goes across the board for almost all types of pain problem. What's important is how we go about it. So in this pain plan, we can set some actions that lead to goals, things that this person thinks matters or wants to have happen in their life. We can set actions that are things that a person does or doesn't do. So we set them to be timed, so we know when the person's going to do it. We know how many things they're going to do, how many times they need to do it, and we know the kind of impact that it might have on doing this thing. For example, if we're going to have a look at sleep management, one of the actions that we might suggest is that we set a regular bedtime and a regular wake time. You either do that or you don't do that. Actions seem to be a little bit better than saying, I'm going to have the goal of going to bed at a regular time. Goals aren't really the things we work towards. So actions that we do or not do. We do daily planning, and this is about keeping our activity levels consistent. When I say our, I'm talking about people who live with pain. I live with fibromyalgia, so I'm kind of putting myself in the picture here. So what I know, and from working with patients, is that keeping a consistent amount of activity every day really helps. It stops us from overdoing on days when we're feeling really good and underdoing on days when we feel really lousy. Why is that important? Well, if you overdo on a day when you're feeling really good, you're likely to get a flare-up. So the next day you will be feeling pretty lousy, and so you won't do so much. And that means it's very difficult to plan. It's very difficult to know that I can do this week, this Friday, because when activity patterns aren't very consistent, we can't predict. So keeping a kind of consistent, bit of a boring routine can be really helpful, because then we can set this level of consistency and we can start to build up our level of capability, our physical capability. The problem with that is mind chatter. Our mind is really good at telling us, oh, yeah, but this is really important. I've got to do this today. And yeah, but if I stop now, I might never get it started again. Yeah, but I tried it and it didn't work because I had a flare up anyway. So one of the challenges for anybody working with people who have long-term pain is that our mind chatter and our emotions can really interfere with the things that we know are helpful for keeping pain and life under control. So we've got various strategies for helping deal with unhelpful thoughts and emotions. I'm a fan of acceptance and commitment therapy, ACT, in which case I'd be recommending that we just thank our mind for having a really good go at us. Thanks for reminding me that last time I did it, it didn't work, but I'm choosing right now to do something different. Or we could just acknowledge that our mind has an opinion on what we're doing and make a decision to do something that's more aligned with what we want to do. Minds are really good at solving problems, but they're not quite so good at being helpful when it's an insoluble problem. And much of the problem with persistent pain is that we don't have a really good solution. When we deal with unhelpful thoughts and emotions, we can also use things like mindfulness, which allow us to create a little bit of distance between this thought or emotion and the attention that we pay, the noticing that we pay to it. So we can step back and just notice those thoughts and emotions come and then go, rather than following their dictates. And we can also look really well at communication. People who live with persistent pain talk about the fact that they find it difficult because people look at them and they think, oh, you look normal. What's wrong with you? And then people can assume that, oh, this person's just being lazy. They're not very motivated. They don't really want to hang out their own washing or do their own vacuum cleaning or whatever the problems are the person has with pain. And so communication is one of the skills that I think is really important, especially if we're helping somebody change their routines or their activities. We want to be able to help the person express the sorts of things that that they want to communicate to other people. We might want to suggest to people that they have a code word for days when they're feeling really awful. They just need some time out. So they might say cabbages. Today's a really bad day. When I say the word cabbages, just leave me alone. And then they might have another way of saying, when I'm feeling a bit more sociable, these are the sorts of things that could be helpful for me. And so making some explicit words and phrases around asking for help or saying no, and feeling okay about saying no and asking for help and accepting compliments as well. The coping skills that we often use in persistent pain management are things like distraction. So distraction is about doing things that matter rather than trying to ignore the pain. So it might be focusing on really mindfully walking rather than trying to avoid or distract from the fact that my feet hurt when I walk. We can look at the sky, we can smell the flowers, we can enjoy the bracing air. It's Christchurch, it's cold, right? So we could use reading books or jigsaw puzzles, lots and lots of activities that can be used to act as a distraction, as long as we enjoy those activities and use them mindfully and thoughtfully. Because one of the problems with distraction is that it can work really effectively and people don't notice the pain until they stop. So they might be loving doing the gardening. Oh, it's fantastic, I'm getting out in the garden. And then there's kickback because, ouch, I did too much. I overdid it, forgetting that consistency. But distraction is a strategy that we can use. Watching movies, reading books, talking to people, phoning somebody up, going for a walk, doing active things. The second thing that is very common and is probably the key approach that we can use for people with pain is movement. Now, this is an exercise-free zone. I don't do exercise because it conjures up for me lycra-clad blokes in a sweaty gym with loud music, and I hate it, so I'm not doing that. But movement is another thing, and we do lots of movement as humans. It's really useful to do movements that involve our big joints. So this is things like walking, it's like vacuuming, it's like hanging out the washing and making the beds and doing the gardening. But it can also be playing tennis or golf, it can be swimming, it can be all manner of things. And it really doesn't matter what exercise we do, what movements we do, as long as we do it, as long as we do it consistently, as long as we increase slowly, so we start at a low level and just gradually sneak the level up, and that we've got lots of choices, so that if it's wet and I like to walk, I've got an option and an alternative. And for me, that's often putting the music on and doing a quick boogie, because it's simple, it's accessible, nobody can see me, and I do 3 minutes here, 3 minutes there, and I break my day up. So it's something that we can all do. So yes, you can have prescribed exercise, but for many of us with persistent pain, it's just about knowing that the things that we do are really helpful for our bodies. Third thing that we use in persistent pain is medications, and we like to use these in a time-based way rather than just as needed. And this is because people often resist taking a medication until their pain's already up here, by which time medications are probably not going to be that effective. And so the person's at risk of saying, well, that didn't work, so I'll take some more. And subsequently can risk side effects and unpleasant effects as well as overdose. So we know that it's better to take a time-based approach to medication so people have a consistent amount. Persistent pain is a long-term condition, so we can think about using medications for persistent pain in the same way that we use medications for hypertension. We don't change the dose on a daily basis. We have a consistent amount, and we allow those little fluctuations that are normal, are part of living, to just be there, and use these other strategies as part of that mix. Pacing activities is the kind of catchphrase for occupational therapists very often. Pacing is that idea of doing a consistent amount of activity over the course of a day, over the course of a week. It doesn't always work, and we don't often pace properly. Speaking as someone who lives with pain, pacing can be a bit prescriptive. And all of us boom and bust when it comes to that period before Christmas Day, when we're rushing around like lunatics trying to prepare everything, knowing that we can crash on Boxing Day unless we're going to do the Boxing Day sales. Don't. It's just not worth it. With pacing though, we can look at planning out the activities that are most important and put those in first, creating a sort of balance in demands from activities that require lots of energy to those that need a little bit less, to activities that use one part of the body and switching to something else that uses a different part of the body. So we can mix and match our overall activity level so that it's much more consistent. Your occupational therapists are the experts in this area. Finally, the last skill that is really useful and probably one of the key skills that in my study looking at people who live well with pain used, and that was mindfulness skills, which was about noticing, ouch, I'm sore, but not buying into, oh my God, then I better not do anything. But just noticing, oh yeah, I'm sore, yeah, I'll probably have to take it a little more quietly today. Not in a boom and bust pattern, but in a, I'll change how much I expect from myself today. I'll be a little bit kind. And on a day when I'm feeling a little bit better, a bit more energized, I might do a little bit more. That idea of noticing without judgment that, yeah, I'm a bit sore. There's more information about all these strategies littered throughout the interwebs and also on my blog. Step 4, and this is a really important one, and I'm going to spend just a few moments on it, which is developing your networks. Interprofessional teamwork is best practice for complex pain problems that last a long time. So in your practice, wherever you are, get to know your pain specialists. These are specialist doctors who have trained in pain as a specialty. There's not very many of them. They're a scarce resource and we love them. But get to know them. Get to know physiotherapists who've had some understanding and knowledge and training in pain. Not everybody has had that, and not everybody is interested in working with people who live with ongoing pain. Same for occupational therapists and psychologists. Clinical pharmacists are fantastic people to use in your team to review both what the person is actually taking in terms of their medications and their understanding of those medications and why they're taking them. And those that have learned about pain are particularly wonderful. Nurses, of course, because nurses care about people, and listening and hearing somebody's understanding of their pain and the struggle that they're going through is a really valuable part of healthcare. Perhaps we don't place enough value on that. Others, pain coaches, osteopaths, chiropractors, massage therapists, acupuncturists, there are a whole raft of them. Just check to see whether the people in your network have had some postgraduate training in pain and pain management, because we know that our undergraduate curricula in health sciences around New Zealand and the world are pretty skinny. So pain management is a team sport. And what they might offer are things like group programs. I developed a program called Springboard that's there for people who live with persistent pain. They might offer acceptance and commitment therapy or cognitive behavioural therapy, graded exercise, graded exposure, specialised diagnosis, coaching, hands-on therapy, and information and education. Lots of things that can just add to that person's pain plan. We need to remember that one size doesn't fit all. Two people with the same diagnosis might not respond to the same approach. So we have to create some wiggle room. And I use the Chinese finger trap as a really good example, because if you pull out from that, trying to do the one solution that springs to mind, you'll be trapped. But if you push in a little bit to the pain and you wiggle a little bit and you find your own route, that can give a mixture of ingredients that really helps somebody. Thank you, ngā mihi, to all of you. And if there are questions, I would love to answer them if we've got enough time. I'll just stop the share.
Yeah, stop the share. You've got plenty of time. You've got 9 minutes, Bronwyn.
Wonderful.
And I'm just going to encourage people again to type their questions in. In the meantime, there has been a really interesting comment from Tracy, who says that this has been particularly helpful in regards to identifying pain in people with intellectual disability. And I wonder what that raises for you, Bronwyn, whether you've got anything to say about that.
It's not just people with intellectual disability, but people with dementia, people who are confused or delirious, people who can't be, who are not able to speak, that we have to work from what the person does and how they respond. And that's fraught with all sorts of problems, but a pain diagram is a really good just way to start. So show me where you hurt. Thinking about people most people who experience pain who are not verbal will withdraw, they'll grimace, they'll wince, and there's very little evidence anywhere to show that people make up pain. And we cannot detect whether somebody's faking pain. We just don't have any way in the world to work out whether somebody's faking. So our best presumption is to treat people as if they are being honest about their pain. It doesn't necessarily mean we'll jump into giving a prescription, because prescribing isn't always the best answer. There are so many different ways that we can work with people who experience pain, but the most important step, I think, is validating that it's real. This is your experience. This is what it's like for you. And that's I think that is actually the role that nursing in particular plays. In an acute nursing setting, say post-operative recovery, monitoring medications, looking at the effect on somebody's respiration rate, on their ability to whether they're groaning as you try to roll them or you try to help them do movements. Those are some of the things that the observations that nurses make are really, really crucial, because nurses observe people over a longer period than an occupational therapist with an hour, perhaps. But it's also easy for us to misinterpret and to judge people because they're not responding in the way that we might respond. And that's something that we need to be very careful about. Pain study in most of our undergraduate training, all of our undergraduate training, really is below par, and we need to do something more about that to improve it.
And it's very similar. Are you looking at the questions, Bronwyn?
Yes, yeah.
You can see that it's about recognising changes too. I mean, that must be very...
It is. Yeah. It's about, so usually people whose pain is relieved will look more relaxed. We think about pain, it's an enormous stress. So we're going to have all of this tense, withdrawing, tension building up, and facial grimaces, and that's the sort of thing that we can observe. And when people are feeling more comfortable, they'll feel more relaxed. I would say, please don't use the 0 to 10 scale when you're asking people about their pain, because if you've got pain, next time you have a headache, I'd like you just to ask yourself, what number would I give this? It's really difficult. 10 being the most extreme pain ever. Is the pain from having bit in your tongue as intense as the pain that you have when you've got menstrual cramping, or the pain when you rolled your ankle? And we don't know. And it's not about the intensity as much as how much is it's getting in the way and what does it mean. And so I think that the question we might ask is around, can you cope with this? Can you manage this? Are you comfortable enough? So that might help change our reliance on the 0 to 10 or 0 to 5 scale. how to manage a person who's being agitated. I actually think sitting and listening is a very good step. A judicious hand touch. So especially somebody who's distressed and agitated, just putting your hand on somebody's hand and stopping, so let's talk. I'm listening. Could be a really good start. And yeah, just perhaps breathing. I use breathing as one of my key strategies, especially in acute pain settings all the time. And the lucky last on tips on getting a good sleep. My mainstay, the normal sleep hygiene stuff, so devices and regular bedtime, regular wake time. It's important to remember that if you've had pain for a long time and your sleep's been disrupted for a long time, it's probably going to take a wee while for your sleep to return to normal. So things like progressive muscle relaxation can be really helpful. Hypnotic induction can be really helpful for people. We can use mindfulness as another really useful approach. Things like changing your bed and your pillow seem useful, but actually the research shows that it doesn't really make a lot of difference. It's much more around how we manage down regulating or calming the body down so that we're okay. So maybe reminding ourselves as we're lying there trying to get to sleep that at least I'm resting, my body's resting, even if my mind's not. But it's a huge topic that we can cover in a lot of detail, and I don't think we can do that in the time we have left.
All right, we've got time for one last question. There's one that's just come in.
Yes. Talking about flare-ups. So flare-ups are a thing, and they are common and part of pain. So if you've got long-term pain, the probability is really high that you're going to have a flare-up, in which case little pain, things that you would normally do and feel okay about doing, suddenly hit you around the head like with a 4x2. So I agree with that. It just suddenly it increases. So having a setback plan and a flare-up plan can be part of that pain management plan. What do I do when the proverbial hits the fan? And that can be sometimes a starting with, oh, that's why I've got a flare-up. Or just recognizing this is a flare-up, this is normal. That all flare-ups settle down. They might feel like they're lasting forever, but they do settle down. That it's silly to expect ourselves to do everything that we would normally do during a flare-up. Be kind. Keep thinking, Jacinda here, I'll put the long earrings on, shall I? And change my hair. But be kind to yourself when you're in the middle of a flare-up. Take it quietly for a day or so and then get back to it. But just ease into it. So it's not a simple answer because it's tailored to what this person needs. And that's the why we work together as a collaborative pair, a clinician and a person with pain. So we can talk about trying this out, let's experiment, and then let's see what's going to help you in this situation.
Thank you. That's really good. Bronwyn, I think it's been an excellent presentation. Thank you so much. That you've framed it around 4 different stages, inviting that conversation, reviewing the impact, developing the coping skills, and then that whole team effort that goes into it. So thank you so